So next is obstetric trauma. You're called to a labor suite to review a 30-year-old lady who is otherwise fit and well and who is 4 days postpartum from her first delivery with frank fecal incontinence. How do you proceed? So I would take a full history about her delivery, like prolonged stage of delivery, instruments used for assisted instrumental assisted delivery like ventouse or forceps, and episiotomy or any tears. And then I will ask about the onset of symptoms, quality and quantity of incontinence like stain, teaspoon, cup full motion, incontinence to flatus, urgency, passive incontinence or urgent continence, previous bowel habits and previous surgery. Use an incontinence score, that's St. Mark's or Wexner or Vasey score, to classify the severity of the symptoms. So this score is consider the seven parameters, and there are 4 grades: never, 0, rarely 1, sometimes 2, weekly 3, and daily 4. So 0 to 4, and then you have to score accordingly. So first thing is incontinence for solid stool, incontinence to liquid stool, incontinence to flatus, change in the alteration in the lifestyle, need to wear pad, using pain constipation medication, and lack of ability to defer defecation for 15 minutes. So maximum score is 24 and 0 is the perfect continent. And then I would ask to examine her perineum, but be conscious that she may be so uncomfortable to tolerate a peer examination, which may be needed to assess the sphincter. She had a second-degree tear repaired immediately post-delivery in the delivery room. Since day one, she reports urgency and inability to hold onto stool with the passage of a cup full of the stool. She is wearing pads, which she changes numerous times a day. I think this lady has a missed third or fourth degree tears, because 1 and 2, they are not involving the sphincter. Only injuries 3 and 4, they involve the sphincter. How would you classify an obstetric injury? So obstetric injuries are classified according to the Sultan classification. First degree tear, injury to the vaginal mucosa or the skin, second degree tear until the perineal muscle, third degree tear involving the external sphincter, internal sphincter, and fourth degree tear, damage of the internal and external anal sphincter complex leading towards the anal epithelium. How would you manage this lady? So in the first instance, I would counsel her about the possibility of missed third or fourth degree tear and discuss with her ops and gynae team, as this is a medical legal issue. And EUA is an option, but at this stage may not be add anything to her management. Lorberg's group showed that repairs of early tears more than 72 hours but less than 14 days without a stoma had a mean Wexner score of 1.1 at 50 months post delivery, but this is likely to only be performed by a pelvic floor specialist. I would advise about the use of loperamide to thicken the stool, skincare to protect her perineum, and arrange to see her in the OSS clinic if available, or outpatient in 2 to 3 months. This lady needs psychological support by giving him Mosaic sport group, and then she needs a bunch. She should be referred to biofeedback therapy and pelvic floor physiotherapy as routine. She is reviewed back in your clinic 3 months post delivery and is still symptomatic. And how would you proceed? So I would perform a workup for rectal incontinence with a history. Again, same question. Examination, incontinence score, which I told that Vasey Zinmark score, refer for biofeedback and pelvic floor physiotherapy. Try loperamide syrup to build up the stool, and refer for an endo-anal ultrasound and anorectal physiology. So her endo and anal ultrasound shows a full thickness defect in external sphincter from 11 o'clock to 2 o'clock, and her anorectal physiology is that her sphincter motor function is less than will then assess the motor function and sensory function on the anorectal physiology. So there is a table given there. So describe the results. This lady has a globally reduced pressure on her manometer, reflecting a problem with her internal anal sphincter and external anal sphincter. The resting pressure and the involuntary squeeze reflect the function of internal anal sphincter. The internal anal sphincter is involuntary muscle, so reduced internal anal sphincter can lead to the passive fecal incontinence or flatent incontinence. The patient will be leaking or passing flatus without the patient knowing. This is called passive fecal incontinence. The peak squeeze and 5-second pressures are a reflection of the external sphincter, which is under voluntary control. A weak external sphincter can lead to urge in fecal incontinence. Patient will feel and then poo will be out. This lady's volumes are also globally reduced, meaning she senses the need to defecate early and get symptoms in small volume in her rectum. This can be improved with biofeedback. When would you consider a delayed sphincter repair? This lady has a moderate defects which may be amenable to surgery, but has physiology to suggest she is symptomatic. I would not consider repair if there's 6 point. If patient is asymptomatic with these endo and ultrasound and anorectal surgery report, if she wants more normal vaginal deliveries, if fecal incontinence is late onset, non-contracting external anal sphincter, and partial external anal sphincter tear, because the risk of further damage and making symptoms worse if the wound breakdown patient may be worse of the, and then obese, increased wound breakdown risk and rectovaginal fistula. Thank you.